In the last week of May 2026, 3 U.S. states moved to regulate artificial intelligence in mental health services. Instead of adopting a uniform standard, they passed 3 drastically different statutes. In Vermont, Governor Phil Scott faced a bill prioritizing absolute prohibition. The Vermont law forbids any AI system from presenting as a source of therapeutic judgment, diagnosis, or clinical communication. It treats the deployment of the model itself as the injury. Meanwhile, in Connecticut, Governor Ned Lamont signed a completely different framework. Connecticut does not ban these systems. It relies on a protocol regime. Operators must publicly post evidence-based crisis detection methods and implement mandatory disclosures telling minors they are talking to a machine. Over in Illinois, Governor J.B. Pritzker backed a third approach. Illinois requires mandatory independent third-party audits for frontier models, forcing developers to hand over weights and risk assessments so external reviewers can probe for failure modes. For software developers, this creates an immediate compliance collision. They must figure out how to ship a single mental health AI product that simultaneously satisfies a ban, a protocol, and an audit. Slapping a disclaimer in the system prompt or tweaking the terms of service no longer provides legal cover. To ship nationally across these diverging state jurisdictions, builders must completely tear down their systems and reconstruct them around a strict clinician-in-the-loop software architecture. The necessity of this rebuild stems directly from the clinical data. A peer-reviewed letter out of Aarhus University Hospital in Denmark took AI harm in psychiatry from anecdotal speculation to an empirical count. This animated diagram illustrates the data funnel from the Aarhus study. Researchers started with nearly 54,000 patients, scanned over 10 million clinical notes, and isolated 181 unique notes mentioning chatbots. Within that subset, they documented 38 cases compatible with harm. Senior author Dr. Soren Ostergaard identified a specific flaw, the validation harm mechanism. A large language model is trained to be agreeable. For a patient experiencing early delusions or rehearsing a suicide plan, that agreeable response fuels the destructive spiral. That clinical reality translates directly into legal liability in the United States, anchored by the Rain versus OpenAI lawsuit filed after the death of a 16-year-old user. The complaint in that case cites specific internal telemetry. It alleges the platform's moderation system flagged 377 of the user's messages for self-harm, with frequencies escalating from 2 a week to more than 20. The platform's moderation layer watched the crisis escalate, while the generative model kept talking. In a courtroom, an internal system logging high-confidence safety flags without intervening establishes documented foreseeability of harm. General-purpose AI platforms complete this dangerous validation loop by design. They cannot be safely deployed in clinical settings. The architecture itself must change. That architectural change begins with Vermont's legal boundary. Under the new statute, it is strictly illegal to offer mental health services where an AI is presented as providing therapeutic judgment. Standard generative AI models fail this test automatically. By predicting tokens to sustain an open-ended conversation, they independently craft responses that function as therapeutic acts. This system block diagram shows the first required module of a compliant architecture, care plan bounded behavior, mirroring platforms like Gemini Health Sage. This boundary physically prevents the AI from improvising. A human clinician writes the action plan, and the AI simply executes those specific, locked-in parameters. Moving to Connecticut, the CART Act conditions operation on a published protocol. Operators must utilize evidence-based methods to detect self-harm and respond according to clinical best practices. The law also imposes a rigid user interface specification, requiring an hourly non-human disclosure for users known or suspected to be minors. Meeting the detection mandate adds a new functional layer to the diagram, always-on high-risk classifiers. These classifiers run independently of the conversational model. They continuously scan user inputs for lexical risk markers, signaling suicidal ideation, psychotic symptoms, or medication noncompliance, instantly halting the generation process when a threshold is met. Detection alone is insufficient without a clinical response path. When a classifier trips, the system bypasses the large language model entirely. It transfers the conversation log directly into a defined escalation pathway managed by a licensed human professional. Finally, Illinois Senate Bill 315 establishes a new national floor for accountability by mandating independent third-party audits. This law targets the heaviest computational tier, triggering when developers exceed $500 million in revenue and deploy models trained on more than 10 to the 26th floating point operations. The independent auditor gains sweeping access. They are legally entitled to examine the model weights, probe refusal behaviors, and map out the system's failure modes. If an AI operates as a vendor-side black box, producing interaction logs for an external auditor becomes a massive, fragmented liability. The final required module solves this through deep electronic health record integration. Every patient interaction, every triggered classifier, and every safety rationale generated by the system is pushed directly into the supervising clinician's native EHR dashboard. By centering the EHR as the single source of truth, the audit trail becomes a continuous native function of the clinical workspace rather than a frantic end-of-year data retrieval effort. Under Illinois law, trade secret protections shield algorithms from the general public, but those shields do not apply against the state's designated auditor. Illinois forces developers to prove their safety testing empirically. Deep EHR integration is the only structural choice that converts theoretical safety claims into an immediately auditable legal document. In a single week in 2026, 3 divergent theories of legal harm materialized. Vermont targeted the deployment itself. Connecticut targeted the missing safety protocol. Illinois targeted the untested frontier model. Despite adopting completely different statutory frameworks, all 3 states force the exact same engineering solution. This is the unified clinician-in-the-loop architecture. It restricts behavior to human-authored care plans, routes detected risks to licensed professionals, and logs every event inside the EHR. A product built with these 3 distinct structural layers can ship into Vermont, Connecticut, and Illinois on day 1, without requiring bespoke legal refactoring for each state line. More importantly, this design solves the underlying clinical threat. By prioritizing structured human routing over machine improvisation, it actively breaks the destructive validation loop observed in the Aarhus data. For tech builders, legal counsel, and policymakers, the message is uniform. Mental health AI can no longer operate as a direct-to-consumer software sprint. The disparate state laws of May 2026 successfully forged a rigorous national baseline. The only legally viable AI in psychiatric care is one that acts as a transparent, tightly bounded clinical extender, leaving the licensed therapist firmly in the chair.